Hey everyone, this is a Pragmatic PT, and today I want to discuss the truth about FAI syndrome. As always, this video reflects my personal opinion based on my own interpretation of the literature. This video is intended to be a source of information and not medical advice. If you are currently dealing with an injury, I highly suggest you seek help from a qualified medical professional. So femoral acetabular impingement syndrome, more easily referred to as FAI syndrome, is a common complaint among athletes. With FAI syndrome, there is many times some anatomical changes that accompany the pain. In this image, you can see what a normal hip joint looks like, and then what a cam and pincer pathology look like. You can see the cam involves additional growth to the femoral head and neck, flattening that area out, whereas the pincer is an overgrowth of the acetabulum. You can also have a combination of both of these things. These bony abnormalities are thought to increase the risk of injuries such as labral tears, which are common with FAI syndrome. The main complaints of pain are typically to the front of the hip or groin region that is worsened when the hip is in positions of deep flexion, such as a squat, or when the individual sits for long periods of time. Now, the first line of treatment for this issue is typically conservative care and will involve a bout of physical therapy. With this, the individual will typically be educated on ways to modify their activities in an attempt to reduce symptoms and allow the recovery process to get a foothold. Added to that, you would likely be started on some sort of core, hip, and lower body strengthening program to try and address any weaknesses in the area. Many times your physical therapist will utilize some form of neuromuscular training to improve balance and motor control at the ankle, knee, and hip as well. In many cases, this approach can be quite successful, and hopefully that is all that's needed. In other cases, the pain may persist, and you'll be advised to get some form of imaging to see if there is damage to the hip joint or the surrounding soft tissues. Now, damage to these tissues, such as the labrum, does not guarantee that you will have hip pain. Studies have consistently shown a large percentage of people to have labrum tears but remain asymptomatic. In one study, 62% of symptomatic individuals had labral tears, whereas a whopping 54% of completely asymptomatic people also had labral tears. Now, if you just want to look at cam and pincer abnormalities, one study showed that cam deformity was present in 37 to 55% of the athletic population and 23% in the general population. Now, 67% of asymptomatic people were also found to have a pincer deformity. So positive imaging for the bony deformity of cam or pincer, or even a labral tear, does not guarantee that the pathology is the sole reason for your pain. Now, let's say you took this information to heart, or just really didn't want to have surgery, so you soldiered on with conservative care, but just didn't get the relief you wanted. What does this surgery involve, and what do the results from surgery actually look like? Typically, the surgery will involve a different combination of things depending on what you present with. If a pincer lesion is noted, the surgeon will likely trim that down, lessening the overgrowth of the acetabulum on the femoral head. They may also reshape the femoral head and neck junction, making the region more rounded to avoid contact with the acetabulum, and finally, they will repair the labrum if significant damage is seen there. Now, as a side note of caution, these surgeries seem to be less successful for individuals over the age of 50, those who present with chondral damage to the weight-bearing surfaces, have joint space narrowing of the hip, or present with more advanced arthritis to the joint. Okay, now back to the main storyline here. Overall, results for individuals without those previously noted contraindications appears to be pretty good. Following surgery, about 74% of people will get back to playing the same level of competition as before the injury, with time to return to sport being on average about 7 months. Now obviously it'd be great if that number was higher, but truthfully that isn't too bad. Surgery has become much more common in the last 15 years, seen an actual increase of about 18-fold just between the years of 1999 and 2009. So because of that, sufficient long-term studies have not yet been done, and due to this, I can't yet speak about the longevity of athletes following these surgeries. One area I feel we still have a lot of work to do is when deciding to release an athlete back to competitive sport. Unfortunately, we don't have a form of standardized return-to-play testing following FAI surgery like we do for other things such as ACL reconstruction. Now you can watch my previous video to hear my thoughts on that, but regardless, standardized return-to-sport testing needs to be implemented in one form or another for this increasingly common surgery. All in all, FAI syndrome and FAI surgery is being diagnosed more frequently, and the surgery is becoming incredibly common in young athletes. Fortunately, the results from surgery appear to be fair, but return-to-play testing is lacking at this point. Another area of concern is the high percentage of people who present on imaging with the same abnormal findings that we'd see with somebody with FAI, but remain completely asymptomatic. Sadly, this is just another situation where we don't have all the answers, so I guess we'll have to wait for the science to add some more pieces to the puzzle.